صباح الخير جميعا. It's my pleasure and my honor to be here with you all, this nice company and this great scientific event. I would thank all my colleagues that have presented their very nice talks before me. This presentation is dedicated to Abu Rish Pediatric Hospital, the place who made us doctors and who made us understanding, and we have the abilities to deal with young children, which is a very difficult age and very difficult type of patients to deal with. We'll talk about the imaging of inflammatory bowel diseases, and the role of imaging initially is to do an initial diagnosis, differentiating ulcerative colitis, Crohn's, and tuberculosis, which are the most common causes of inflammatory bowel diseases in children. Assessment of disease course, extent, activity, and response to treatment, and as well as the complication of disease and extraintestinal manifestations. Here is a small differentiating points in between the three major causes of inflammatory bowel diseases, which are tuberculosis, ulcerative colitis, and Crohn's. The TB likes to affect the ileocecal valve and terminal ileum because of abundance of lymphoid tissue. Presence of lymphadenopathy with caseations or calcification favors the tuberculous etiology. Other organs involvement also would suggest tuberculous etiology. Peritoneal involvement is with tuberculous etiology. Here is a small diagram that presents the underlying pathological process that comes with any inflammatory bowel disease. First, it would affect the bowel wall, causing wall thickening, and then it would cross to the cause congestion of the vasa recta because of the hyperdynamic circulation, hypertrophy of the mesenteric fat, presence of peri-ileal and peri-mesenteric lymphadenopathy, and then when chronic diseases, healing by fibrosis would go into formation of strictures, or in more complicated cases, it would cause fistula, abscess formation, bowel perforation, and eventually malignant transformation. The role of imaging would differ according to the type of imaging facility that you have and you are dealing with. The plain X-ray, I think, is more dedicated for detection of complication that the patient is coming for with acute presentation, so it's very beneficial for you to do a plain X-ray. It may show some of the famous signs that we are familiar with, you are all familiar with, which is the extensive mural thickening that gives the thumbprinting appearance. Maybe at the right iliac fossa, indicating the ileal affection, or at the hypochondrium, indicating the splenic or hepatic flexures, and also it may indicate the eventual complication by bowel ischemia. Toxic megacolon is a very important complication, is a very common complication with patients of inflammatory bowel diseases. Present with huge, extensive dilatation of the colon with extensive mural thickening, mural edema, and eventually would go into perforation if not treated. And then we come to the ultrasound, which is a very important and very sensitive and very easily acceptable exam to do in pediatric children. Believe me, I'm so close to the agreement or the concept that there is nothing in the neonate or the young children that you cannot see by ultrasound. The ultrasound is very sensitive and is very informative. The resolution of the images are very fine and is also being accepted for the operative team. The first thing that you have to know about the bowel ultrasound is the detection of the normal appearance, which is, I think, it presents more than 50% of the diagnosis. Normal appearance of the bowel indicates the presence of multiple layers, or the preserved stratified appearance of the bowel wall. From inner to outer, there is the echogenic wall that presents the interface in between the lumen and the mucosa, and then the hypoechoic wall that presents the mucosa, echogenic wall presenting the submucosa, and then the musculosa, and then lastly the serosa. This is called stratified appearance of the bowel wall, which is the normal appearance. Also, the normal appearance, the difference in between the types of the bowel that you are examining. I suggest that you have an scheme for examining the bowel, starting with the right iliac fossa, that is the site of the ileal accumulation. Ileal loops are characterized by being wide, with the mucosa regia are not so much thick. And then at the left iliac fossa, where the colon is present, which is being large, wide, having fecal content, having air locules. presence of the haustration also characterizes the normal appearance of the colon, and then at the left hypochondrium, you can see the jejunum, which is of narrow diameter than the ileum, but is characterized by having a more thickened mucosal roget, which is the feathery appearance. For me, the most important sign and the very early sign of bowel affection is the loss of peristalsis. So when you examine the bowel, the first thing that you have to comment on is the normal peristalsis of the bowel. Later on, there will be diffuse mural thickening. The mural thickening should be measured from the inner wall of the bowel until the outer wall. The first sign is the thickening of the bowel with preservation of the stratification of the normal layers seen at the normal ultrasound. It was detected the focal or segmental loss of stratification correlated with disease activity, which is a very important data that you should report in your report of bowel ultrasound. And focal destruction of the wall stratification also is caused by deep longitudinal ulceration, and eventually it would predispose for bowel perforation. An asymmetric segmental bowel thickening, so-called the cobblestone appearance, is a manifestation of Crohn's disease. Here is an image that shows the diffuse wall thickening with preserved stratification, asymmetrical wall thickening with impending perforation. And here is the, we can see the jejunal bowel lobe, which is having a diffuse wall thickening with preserved stratification, but also you can appreciate the abundant or the hypertrophied mesenteric fat, which is also a sign of inflammation. Note that the bowel is fixed, dilated, with no evident peristalsis. Another example for diffuse wall thickening, but I think the stratification here is starting to disappear, which is a long-standing case, because of the fibrosis would prevent the normal peristalsis of the bowel. And so when there is a lack of peristalsis, also you should suspect underlying fibrosis. In long-standing cases with complication, it would complicate with fistula formation, abscess formation, which also can be detected by ultrasound. Fixed bowel lobes, even without dilatation, but with wall thickening, even with preserved stratification, means that there is also an underlying or surrounding fibrosis, which is denoted by abundant hypertrophied mesenteric fat. Other extraintestinal manifestations can also be detected by ultrasound, including cholangitis, steatosis, chronic hepatitis, cirrhosis, and gallstones formation. We can add the mesenteric fat hypertrophy, enlarged lymph nodes, and free fluids. The detection of disease activity, especially in chronic patients, is a very important data that you have to report while examining the baby, because most of the patients are chronic and presenting with acute presentation, and the physician wants to know whether there is a relapse of remittent disease or there is an indicated disease activity or emerging complications. The use of the Bowel Doppler would help you very much in detecting whether the disease is active or not, by detecting the hyperemia or increased Bowel Doppler signal at the bowel walls. Also, when you can also use the spectral waveform analysis for the blood supply. In the active disease, there will be reduction of the velocity because of the increased diastolic flow, which causes that the velocities would be reduced, and the pulsatility index, RI, will be also reduced. When you follow up the patients to detect the remission or exacerbations, you will see and you will appreciate that the velocities will regain to their normal values when the patient is improving, and the RI PI will regain their normal values with increased compared to the previously detected numbers. So to sum up, the ultrasound indices for disease activity includes the bowel thickness, the Bowel Doppler signal, wall stratification, in addition to the compressibility, the fat wrapping, haustration, and the presence of peristalsis. Multiple indices were generated by multiple authors in order to detect the disease activity, so it is a very important data to delineate in your exam, depending on the bowel wall thickness, depending on the stratification, and depending on the Bowel Doppler signal. Another disease activity scoring for the ulcerative colitis, also depending upon the previously mentioned factors. Now we come to the fluoroscopic barium meal follow-through, which is, I think it's going to be, its importance is going to be very much declined in the next era because of the development of the more recent MR enterography that saves the radiation exposure for the patients and does not depend upon the proper filling of the bowel. But it saves the facility of being real-time imaging, and would also show the presence of the complications, whether it is strictures or the perforations or the couple stone appearance in cases of Crohn's disease. In cases of ulcerative colitis, we are all familiar with the appearance of the ulcerative colitis, which is the pipe stem appearance, and the presence of multiple small minute ulcers. Crohn's is characterized by having the couple stone, multiple polypoidal mucosal folds thickening, may have fistulous complication or periileal abscess formation in very chronic or complicated cases. Here is an image that shows the pseudopolyp formation denoting the polypoidal mucosal hypertrophy, and here is multiple ulcers with also multiple phenolic defects presenting polypoidal mucosal hypertrophy. The CT enterography is also a very important tool for diagnosis, but also depends upon the proper filling of the bowel, and which is a very difficult thing to achieve in these children, because they always came presenting with cachexia and bad feeding. So if you can do it, would be very fine. And also we will do the triphasic study for the liver, and we do triphasic contrast administration. It will show the wall thickening, increased wall enhancement, submucosal edema, fat deposition, strictures, fistula, toxic megacolon, vascular occlusion, and mesenteric lymphadenopathy. And also in the ulcerative colitis, it will show the classic pipe stem appearance and the multiple ulcers. Please appreciate the presence of congestion of the vasa recta, giving the comb appearance, mesenteric fat infiltration. Here is another pattern of severe mucosal edema, mesenteric fat strandy infiltration, multiple small enlarged lymph nodes. Another example for active inflammatory bowel disease showing extensive wall thickening, and please also note the preserved stratification, multiple ulcers, strandy infiltration of the mesenteric fat, and in this case is much more complicated, showing multiple ulcers with fistula formation and impending abscess formation. Another CT enterography, which is done in an older children, so the bowel is properly filled and shows the congestion of the vasa recta, shows the stricture formation, mural wall thickening. Another example for the extensive wall thickening with, I think there is also loss of stratification, multiple enlarged lymph nodes, and association of the mesenteric venous occlusion, which is a very important data that you can get from CT enterography with triphasic study, and can also be detected by ultrasound and power Doppler study. So don't forget to assess the mesenteric axis when you do an ultrasound for a baby or a children complaining of inflammatory bowel diseases, whether it is chronic or is coming for screening. Reversible or irreversible stricture is a very important data to mention, and usually the reversible stricture shows diffuse contrast uptake with fat stranding and preserved wall stratification, vasa recta engorgement. The lack of mural stratification or poor contrast uptake suggests fibrosis. And then we come to the MR enterography or the enteroclysis, which is a very important and very promising diagnostic tool, because it saves the radiation, and it also keeps the advantage of being real-time images, especially when you use the diffusion-weighted images and cinematographic views of the baby. It will give you a very clue about whether the presence of obstruction or presence of stricture formation at specific part of the bowel. It will show the mural thickening, which is a layered pattern of enhancement, or giving, presenting the target sign or the double halo sign, meaning that there is a wall thickening with preserved stratification. High mural signal intensity relative to the muscle on fat suppression, denoting bowel wall edema, fibrofatty infiltration of the mesentery, which is comb sign, also in conjunction with congestion of the vasa recta, with multiple mesenteric lymphadenopathy. Here is the examples for the sequences used for MR enterography. Here is the T2 weighted phosphin echo weighted images, and here the post-contrast fat suppression. A child diagnosed by inflammatory bowel disease and shows the post-contrast fat suppression images, shows the extensive wall thickening, will contrast uptake, will comb appearance representing the fibrofatty infiltration and the congestion of the vasa recta. And here is the follow-up of the same patient, giving done with the same sequences with contrast administration also, and shows the appreciable regression in the wall thickening and in the vasa recta congestion and the degree of contrast uptake. Another examples for MR enterography, and see how much is very sensitive in delineating the luminal narrowing, mucosal thickening, with contrast uptake, denoting that it's not an irreversible stricture, or the element of fibrosis has not come yet into a very notable appearance. Here is the target sign, or the halo sign, meaning that there is a preserved stratification. Engorgement of the vasa recta with small enlarged lymph nodes. Here is the bowel wall thickening with fistulous formation and concentric contrast uptake, the fat suppression images, with formation of the pericecal abscess formation. Multiple strictures delineated by the MR enterography, and the contrast uptake, as we said before, is an indication that it's not yet an irreversible stricture. Whether the disease is active or inactive by MR enterography depends upon multiple factors. The first is the inflammatory mesentery, which is denoted by engorgement of the vessels and presence of the lymphadenopathy, bowel wall thickening, with stratification, increased mucosal enhancement, the submucosal edema, and the abscess of fistula with perforation of toxic megacolon, which are the complications of the disease. Inactive disease would be showing fibrofatty infiltration of the mesentery, homogeneous wall thickening, led by appearance of loss of frustration of the colon, submucosal fat showing low signal intensity in T2 weighted images on fat suppression. The fibrosis will be low signal intensity in T2 weighted images with or without fat suppression. There is the illustration for the previous data that we have sent, indicating the scoring of whether the disease is active or inactive. Extraintestinal manifestations also could be seen by the MR enterography. If you can do MRCP also, if the patient is suspecting is having a cholangitis, or if the patient is having suspected to have a perianal abscess, also you can do MR fistulography. Here is examples for the perianal abscess formation. More advanced the studies beside the MRI diffusion is the elastography and the contrast enhanced ultrasound that has not been accomplished as a diagnostic tool in Egypt. But we have done a paper that we have successfully published using the grayscale ultrasound of Doppler study beside the strain elastography, comparing the strain ratio between the bowel wall and the smooth muscles. And you will be surprised to know that comparing the indices of the elastography compared to the Doppler study and the bowel wall thickening, it gives very much less sensitive data, in detection of the disease activity prediction and in detection of the disease activity. But if we combine both the three figures together, it will give a very important and more sensitive indices for detection of the disease activity or the activity prediction. So we recommend that in doing an ultrasound, that we combine all these factors together in order to improve the sensitivity and the specificity of the exam. And thank you for your listening.
حاجه حضرتك الاستوجرافي. طبعا انا ما اشتغلتش الجزء ده، بس عايزه اسال حضرتك، دايما الاستوجرافي احنا محتاجين الاورجن يبقى فيكسد شويه.
محتاجين ايه؟
الاورجن يبقى فيكسد عشان اقدر اعمل عليه الكومبريشن بتاعي واقدر احسب الاستوجرافي.
انا ده مش شير ويف، ده سترين. ده مش شير
ويف. انت اشتغلتي على الشير ويف؟
لا اللي انا اشتغلت عليه ده سترين الاستوجرافي، اللي هو زي البريست وزي الثايرويد، لان هي دي الميزه بقى بتاعت الاطفال، لان انا ما عنديش بادي ويت بادي فات
هيسمح لي
كتير، فانا
بالpenetration.
مجرد باللينير بروب هقدر ان انا اجيبها
بس
على
ده في
طول.
الحاله دي لازم يكون اوريدي الانفلاماتوري باول وصل لمرحله مثلا ماس او حاجه بحيث ان انا اقدر اعمل عليه المانوفر، ولا حتى
لا.
لو هو ستيل موفينج في ايرلي كيس
انا اشتغلت على حالات نورمال
بس
عشان
حضرتك
خاطر
عشان
اعمل
تشتغل.
نورمال كنترول.
وقدرتي يعني مع الموفمنت. طب انا لازم اجرب بقى.
لا هي اصل الموشن ما بتبقاش سو ماتش يعني فيجرس لدرجه ان انا ما اقدرش ان انا اعملها
وانا بستغل صح ان ما فيش عندي وول خلاص، فاقدر اوصل بالبنتريشن بتاعي بالكمبريشن. لكن انا عشان كده بقول لك انا يعني لا انا هجرب باذن الله.
لا ممكن ان احنا نعملها في الوول، وحضرتك بتكمبير بالسموث ماسل، غالبا بتبقى الراكتس فيمورس،
بقارن
بتاخدي بتاخدي الريشيو ان بتوين، ولما تاخدي الريشيو ان بتوين ده في النورمال كنترول تقدري تعمليها برضو في
بس طبعا لو
الاذر
هو
باول.
كومبليكيتد كيس وكده وبدات تبقى ماس هتبقى بالنسبه لي اسهل في الشغل، لان اوريدي تبقى هارد شويه بحيث ان انا اقدر اعمل المانوفر.
انا عايزه اقول لحضرتك
انا ملخبطه يمكن ما بين
السترين الاستوجرافي is not indicated to do advanced case. لا بالعكس، ده انا بعمله عشان خاطر اعمل early detection.
الايرلي، ما انا قصدي كده لو ايرلي ما بيكونش لسه بقى عايزه اشوفه
والله ممكن
كستيفنس. يعني حضرتك بتعوضي
احنا ممكن نعملها
عشان ايه؟ عشان الستيفنس ولا عشان الستيكنس؟
احنا دلوقتي المشكله كلها في الانفلاماتوري باول حاجتين مهمين. اول حاجه الديتكشن اوف early disease، ولما الديزيز يبقى established detection of activity او الريميشن والاكسسربيشن والكومبليكيشن. فانا السترين الاستوجرافي انا مش هستخدمه خالص في كومبليكيشنز، انا بستخدمه بس في يا اما في الاكتيفيتي يا اما في الايرلي ديتكشن.
هيفيد حضرتك بايه؟ يعني هيديك ايه معلومه زياده عن السونار العادي والدوبلر العادي؟
لا هم بالنسبه لهم الايرلي ديتكشن بيبقى فيري
لا مش في الايرلي ديتكشن. انت كابلايد على الالترا ساوند ايه اللي هيطلعه لك يقول لك ان انا لسه ستيل ايرلي وفي المرحله دي؟
السترين ريشيو لو هي ما انا وصلت الكات فاليو معينه، لو هي زادت عن الكات فاليو ده يبقى ده اتس ان انديكيشن ذات there is a disease، او ان الاوريدي بريزنت ديزيز از اكتف، او ان الديزيز اللي كان في ريميشن بقى فيه
اكسسربيشن. حضرتك قارنتي في الدراسه دي بالدوبلر؟ يعني مثلا احنا في الدوبلر كنا بنقدر نعرف مع من شكل الباور دوبلر او من نسبه الار اي لما بتنزل قوي معناه ان هو حصل فازو دايليتيشن والار اي بتنزل في ريزيستنس، فانا باخد الرقم ده واقارن بوست ثيرابي او بوست ما الريميشن تروح. ايه الفاليو اللي طلع عند حضرتك بقى؟ الريشيو دي هي اللي طلعت؟
ما انا وريت لحضرتك الجداول.
لا حضرتك لقيتيها هي اكتر سنسيتيفيتي عن الدوبلر؟
لا الدوبلر
احسن؟
لا، بس هي الفكره بقى، ما ده اللي انا قلته، ان هي لو احنا عملنا يعني مثلا سي البي فاليو مثلا بتاعت الدوبلر طلعت 87، بس لو انا عملتها يعني عملت كومبايند بالسترين الاستوجرافي هتطلع 100%.
يعني هتحسن لك السنسيتيفيتي، لكن انت لا تستغني عن الدوبلر. لا
ما استغناش عنه، بس هي المشكله بس كلها
بس مش كل الناس عندهم يعني طبعا
ما انا هقول لحضرتك
مش كل الناس تقدر تعمله.
المشكله بس في الالترا ساوند زي ما قلت لحضرتك، ما فيش حاجه في البيبيهات او في اليونج مش هتعرفي تشوفيها بالسونار
طبعا،
بس هي المشكله في ان هو اوبريتور ديبندنت.
اصل احنا متحيزين جدا للسونار وللكونفنشن. انا كونفنشن مع السونار، فحضرتك طبعا فعشان كده انا اي حاجه بنلاقيها ممكن تفيدنا في الاطفال بالالترا ساوند بنمسك فيها.
فهو دلوقتي انا الالترا ساوند while examining the bowel I cannot delete الجراي سكيل والدوبلر سيجنال، ما اقدرش، ولكن انا بحسن السنسيتيفيتي بتاعتهم بالسترين الاستوجرافي. وطبعا احنا لما هنزود الستاديز بعدد عيانين اكتر الكات فاليو هتبقى مور اكيوريت.
ميرسي دكتوره هديل.
شكرا جزيلا للدكتوره هديل.